It's all in your head. You don't look sick. Your tests are normal. It's probably anxiety. There's nothing wrong with you. Have you heard these words from physicians, family, and friends? If you're someone who has been struggling and swirling through the revolving door of healthcare to find answers about your health, or if you know someone who is going through this experience, then this podcast is for you. Welcome to the Desperate for a Diagnosis podcast with Laura Nozicka.
Hello and welcome to the Desperate for a Diagnosis podcast. I'm Laura Nozicka, your host. And today we have with us Dr. Lauren Strauss, and we are going to talk about something that I don't talk about that often, and that is different subspecialties within pediatrics. So pediatric is very broad, but we are going to be talking with Dr. Lauren Strauss, who is a neurologist, but she has, of course, a pediatric specialty, and we're going to talk about some maybe lesser known pediatric neurological conditions that people probably don't know about and probably wouldn't be on the radars maybe of most parents until things start happening. So let me tell you a little bit about Dr. Strauss, and we will get into this really fascinating conversation because there are some new diagnoses out there and new treatment and lots going on in pediatric neurology. So I'm excited to talk with her today. So let's learn a little bit about Dr. Lauren Strauss. Dr. Strauss is one of the few UCNS certified pediatric and adult headache neurologists in the country. I am very impressed already. Her clinical passion is helping children and young adults with refractory headaches. She trained in general pediatrics at Northwell Health Cohen Children's Medical Center, followed by child neurology at Harvard University's Boston Children's Hospital. She received her headache specialization after a headache medicine fellowship at Brigham and Women's John R. Graham Headache Center, and she now works at VCU Health Children's Hospital of Richmond. This is one impressive lady, everyone. So listen up today. Dr. Strauss, it's so nice to meet you, and thank you for being with me today.
It's my pleasure. I'm so glad that you're shining a light on a lot of rare disease. This is amazing.
I just feel like there's so many unknowns. There's so many challenges out there with rare disease overall. And really, this is where patients get so frustrated in the diagnostic process of trying to get to what's causing pain and symptoms and all of these other rare conditions that are out there that a lot of them don't have that much support from a research standpoint. So kudos to you that you are diving into some of these rare diseases, let alone pediatric diseases. And again, kudos to you for your pediatric specialty, because I don't have children, but I can't imagine what it would be like trying to have to be the super sleuth in trying to figure out what is wrong with a child. And that has to be so challenging for you.
Yeah, I actually, when I describe this, what do I do to my own children? I do describe it like being a detective. I'm looking around, trying to figure out clues and trying to piece together all the clues, almost like a puzzle. I got this piece. Where does it all fit together? And sometimes it takes a lot of time to get all those pieces together.
Yeah. And even with adult medicine, it takes a long time to get to a diagnosis, and sometimes several physicians as well. And so that's what I hear a lot from the patient guests that I've had on my show. And as I've mentioned to you, I'm a market researcher during the day, although it is daytime. But my other part of my life, my work, I'm a market researcher, and so much of that I've heard from patients who have said has just really been a tough go in terms of getting a diagnosis. And I have had a few parents on my show, and even more frustrating. And I always am in awe in what parents will do for their children to get a diagnosis, to get them pain-free, to help them live a better life. So it's really a harrowing experience for not only the children, but certainly the parents who have to be the ones to worry about it all the time, always on their minds.
Right. And really, in the end, I give this coaching to a lot of my patients. It's like you, and to our learners who are navigating this world and entering and will be our future, said we have to trust parents. When a parent gut says this is not right or I'm worried, it's our job to understand the why. And maybe we haven't asked enough questions. To maybe there's some part of this and they couldn't express it the way that we understood it, but keep asking the why. Why are you so worried? And tell me more about that worry and what are those symptoms that, is making you worry? And keep focusing on that and learning that a parent knows their child the best. And we're getting to meet them and getting to know, that child and their family, but they're living with this patient and this is their child. It's almost an intuition. And so if they're feeling it's not right or I'm not settled with these answers, it's our job to figure out the why, but also sometimes educate them on why we're not worried. So it's a partnership.
Yeah. Yeah. I think that's great because a child, and depending on how old they are, and even an infant, a toddler, et cetera, can only articulate so succinctly as to what's going on with them. So absolutely, I can see we're relying on the parents who sees the child in action on a day-to-day basis, and they know when something's amiss, when something's off.
Absolutely.
Yeah. So we were talking in our pre-chat a few weeks ago about some of the diagnoses that maybe most parents wouldn't be aware of. But I'm curious about just in the last 5-10 years, how has working with pediatric patients from a neurology standpoint changed, and how has identifying rare disorders changed for you? What have you seen?
Yeah, it's an exciting time to be in pediatric neurology. The field is continually advancing and has advanced so much, even in the time that I've been out practicing. I've been out practicing about 10 years, and every year there are new updates, there are new diagnoses being identified, new genes that we're tying to some diagnoses. And then that opens up new therapeutic targets, new medicines. And it's really exciting. So the brain has always been fascinating and it's challenging, right? Because the brain can control almost any aspect. It's a control center, it can control any aspect in your body. And when it's not doing well or has dysfunction, it can manifest in so many ways. So it is an area that can be very challenging to practice in. And also it makes people hesitate to focus in this area because they're like, that's so hard, right? There's so much going on, so much I need to learn. But it's so exciting to be in this field because we're learning so much. And if you love to learn and you love to, be a puzzle maker, as I said, working on that. And now we have a wave of new treatments coming out. So in the past, there were diseases that we thought of as a death sentence, something would be progressive. You have a baby meet a diagnosis, and then over time, within a few years, it could be tragic. It's an awful place to be in as a neurologist, say, this is where we're going, and I'm explaining why. And now we have some new treatments in some of these diseases that can be curative or at least slow down that progression so a child can have a meaningful life. And there are lots of diseases where this is happening in. So it's exciting.
Yeah. What are some of the few that bubble up to the top in terms of most exciting?
Yeah. The one that really so SMA, which spinal muscular atrophy, there are different types and also different levels of effectiveness, but there are some new treatments there, and it's really a game changer. It's changing the whole conversation around this disease.
Wow. And that's exciting to know that progress is being made on a pediatric scale, because not always peds diseases are high on the priority list, let's say, for whether it be research or pharma potentially. So that's fantastic that there's some new treatments on the horizon. But we talked about some, I always say I like the weird stuff. And I think so I mean the rare things, but the rare diseases, but that's, I feel like, again, so many of the patients that I've talked with who have just struggled with a diagnostic journey, it's always been rare, but almost sometimes obvious conditions at the same time, and not not all doctors know everything. I don't think patients expect them to know everything. But when you're in pain, or in this case, your child is in pain, there is a desperation and a misunderstanding of why can't this doctor get to what my kid needs and fast. But like you said, it's putting together the pieces of the puzzle. And there's a few conditions that you and I were talking about that are definitely like, I don't know, like the 1,000-piece puzzles, or the puzzles that have the most pieces to it. But must be so rewarding for you to finally get to a place where we're getting to a diagnosis. So, Dr. Strauss, why don't you walk us through some of these lesser known conditions that have, again, a lot of enthusiasm behind, whether it's a treatment or a diagnostic pathway? Tell us about some of those.
Yeah, and I love this opportunity because we're highlighting things that we might be describing as really rare, but the more you highlight it, it speeds up diagnosis. It allows maybe those who wouldn't have achieved this diagnosis have that diagnosis, and then the more that become aware of this, maybe we can study it as a group and learn more faster, right? So it is important to have opportunities like this to highlight these kind of things. So I want to say the first one, which I just think has such a neat name, so it really stands out, is Alice in Wonderland Syndrome. And so it is fascinating to me, and maybe an inspiration, that Lewis Carroll was probably, we think, a migrainer himself. And so he depicted what we've described as a medical diagnosis. So what this looks like is, without warning, you can all of a sudden experience distortions in space and your perception. And oftentimes this can happen in a child. So you can have like a 4 or 5-year-old all of a sudden looking in their room and notice that everything just looks different, almost like the scenes depicted in Alice in Wonderland, where a door looks smaller. They go to reach for a doorknob and it seems further away because that perception of space is off. And then their mom comes in and said, "Hey, what's going on? I thought you were coming downstairs." And they look at their mom and they're like, "Whoa, her face looks like Picasso. Like one eye is bigger, one eye is smaller." And mom's like, "I'm worried about you," reaches out and you can see that one arm or hand is bigger and the other one's smaller. Then you start looking at your own body and you notice different body parts are different sizes. So truly what you'd say, almost like a psychedelic experience, right?
Wow. Wow.
Yeah.
And I'm sure when a parent, and I'm guessing, a parent would hear the description of what this child is seeing, and I'm assuming right off the bat they're thinking, "Oh, making up stories."
Right. You're a magical thinker. Yeah.
Imagination. I love that about my kid. Creative. But if that goes on for a certain amount of time, at what point is a parent thinking, "Oh, this is weird. This is not right"?
Right. And it's so interesting because Alice in Wonderland syndrome rarely reaches medical care. And some of this is because a child doesn't, like you just picked up, maybe they can't report that they're worried, or they may not be worried. They're like, "This is kind of interesting." And a parent may dismiss those symptoms because they said, "Oh, it's just this." So this presentation or this phenomenon may not always reach medical care. However, what's interesting is there's an estimation that about 1 in 10 migraineurs actually have experienced this at some point in their life.
Interesting.
So a lot more common than we realize. So rare in our medical clinics, but it's probably the more common experience than we're realizing.
Yeah. So what might be considered a superpower for a kid, it's really a manifestation of a migraine, is what you're saying.
So it's interesting. This constellation of symptoms can last hours or days, and it can happen just once, or it can happen multiple times. And sometimes it's even associated with distortion in time, or perception of what time and how much time is going by. There's lots of levels of severity, but you don't have to go on and be a migrainer, but we do know there's an association with the migraine genetics. And during an episode, they don't initially have pain. So if they had a clear headache, that would maybe tie to the parent, "Whoa, there's something different. I'm worried." They may not have a headache during this.
Yeah. At what age, or what's the youngest age that you've seen this manifest or present in a child?
Yeah. So the youngest patient that I've cared for has been around 4 years old. I think that it could honestly happen at any phase of life. but it's more common in those younger age groups. And so more in that kindergarten or, right early elementary age. There are viruses that can definitely bring this out. Epstein-Barr virus, or we call it mono, is notorious for bringing this out. So if you identify this or it comes across or you're worried about it, you would want to ask for in your medical assessment, say, can we screen for some viruses or make sure there's not other things that we'd be worried about that in the setting of a virus.
And for parents observing these types of symptoms or characteristics in their child, is it something where it's detrimental if they don't bring a child into the doctor for an assessment? Is there a risk to waiting and just kind of saying again, well, my kid's really creative, it's your superpower or whatnot, however they might describe it. But is there a risk to not bringing them in for care?
Right. So if it is in the setting of a migraine variant, we wouldn't think that is concerning. And most viruses, good immunity in children. A lot of times they come and go. So, it probably depends on what the cause is. But if it is recurring and there are multiple episodes, then you definitely do want to seek out medical attention. And the reason is there's also, other than it being migraine genetics, there is a possibility that this is seizure. And so you don't want to miss a diagnosis of epilepsy because there are, important reasons why we treat epilepsy.
Right. So again, a presentation like this with these distortions, you mentioned migraine, you mentioned epilepsy. Are there other conditions on, as you physicians refer to, the differential list, all the other possibilities? Are there other possibilities for this type?
Yeah. Other than infection as that third category, those would be the three top areas to be make sure that are considered.
Yeah. So what's your approach at that point from the standpoint of putting this puzzle together and then treatment?
Yeah. So because I'm so subspecialized, the ones that reach me usually are going to be recurrent. And if I see them in enough time that it makes sense, I'll do screening myself for mono. And even the mono titers, EBV titers, they can look for past infection. So even if it's been a few months, even though it's a common illness in childhood, I still may do that titer just to look to see if there's a prior history. Sometimes I'll also do some vitamin screens, other things, just to make sure it's not a nutritional difficulty. Then I'll order an EEG, a brainwave study.
Yeah. And first line of defense, if you will, a parent would come to go take their child to their pediatrician. And so what do you think is happening in the pediatrician's office when a parent brings their kid to the doctor and talking about these manifestations, these kind of imagination things that are happening? What do you think the pediatrician is thinking at that point, and what are they looking at that may or may not be a disconnect with your specialty and what is actually going on?
Right. I think it's important to screen for other infectious signs. And then is it persisting? Is it continuing? Maybe this is a point that a primary care physician or provider may say, I've got to refer you into the hospital. Like maybe we're not going to wait for a clinic visit because it's continuing. And we might want to be able to do faster testing. Is this a brain infection? Like, does this need imaging to sort that out? Does it, do we want to move that EG up earlier and do that while they're in the hospital? So if it's persisting, this is often a good reason. And our primary care providers often are involved in saying, you know what, taking the whole picture together, this might require more urgent attention and refer in. There also is in older patients the possibility that this may be related to drug use, illicit drug use. And so having that uncomfortable but important conversation to sort out if that's a possibility too.
Older patients, meaning older pediatric patients?
Yes, some of our, teenagers. And there's a lot going on nowadays, and vaping is occurring. And so it's hard to be a parent nowadays and fully know everything that is going on. So it's a good time to reassess, are there other possible causes for these distortions?
So with Alice in Wonderland syndrome, is that been specific to this potential migraine genetics or disorder at that point, or is Alice in Wonderland syndrome connected to, again, some of those other things?
So when you mention Allison, the first thing we're going to think about is migraine. But with migraine, it's, that it's a migraine variant, that you carry those migraine genetics and in the future are probably going to be a migrainer. But it's also a diagnosis of exclusion. So if it's severe, if it's persisting, definitely get medical attention and let them think through those other categories to make sure they're not missing anything. But if testing looks normal, we're going to then go back to say, you know what, that's probably related to migraine.
So what's a parent to do at that point? We get this diagnosis of Alice in Wonderland connected to migraine. Now what?
It's a great question. If there's pain with it, I think, it's reasonable to start thinking about, do we want to treat this? If it's occurring frequently and we feel comfortable that it's not another cause, it's not seizures, do we want to treat this like migraine? And I think that's a reasonable consideration.
Yeah. Yeah. So what else is rare and unusual out there that parents struggle with from the standpoint of getting a diagnosis?
Yeah. So I think since we're already talking a little bit about migraine variants, or we say, episodic syndromes or periodic syndromes, it's the same kind of terminology. I'd love to highlight another one. This is now in the super rare. So we're talking like 1 in a million kind of diagnosis. And this is where, and again, related to migraine genetics, but where a infant, and a lot of times they're between like 9 months to 12 months of age, they start presenting with attacks of half body weakness.
Mm.
So all of a sudden they can't move their arm, their leg, and they might have some funny eye movements part of it. They might be in pain. They might stiffen an arm or leg. And you can imagine this is terrifying. It's probably terrifying to also all the medical providers when they come to assess a patient like this. And it's hard because a young patient, we're looking for subtle signs, like they won't use their arm or they're keeping their arm to their side. So, but once you notice it, you're like, oh my goodness, could be very serious. So some of the things that we'll think about are, is this a stroke? And fortunately, pediatric patients, even infants, can have stroke. So you don't want to miss a stroke. This is something that definitely in stroke identification and management, the huge learning point there is act fast, present fast. So if you have any worry, this is not something where I want you to go to the pediatrician's office and think about it, examine and what's going on. It's like, if this is an acute change, then we need to go into the emergency room or call an ambulance, honestly, so we can get there super fast and get it on their attention. So a stroke is definitely in the consideration. Other thing is that it could be a seizure. Babies or young kids are very interesting in that they can have a seizure, and when the seizure ends, that area of the brain needs to recuperate and regroup, and then it can look like weakness. So it may be that the weakness in the arm and leg is actually the aftermath of a seizure that came and went and you didn't see it. So it could be a seizure. So that requires evaluation. And anytime something is a new neurologic symptom as serious as that, it probably needs imaging to also make sure there's not infection, just like our same discussion before, but looking for brain infection or viral illness or something like that.
Right. Yeah, Dr. Strauss, you had mentioned migraine genetics. I don't know that most people realize that there is a genetic component to migraine. Tell us a little bit about that and how migraine runs in families.
Yeah, and this really is an area we want to understand a lot more in. But it makes sense, right? So you see families that, you have one child who's dealing with migraine, and then you ask, who else has migraine? And it's like, well, great grandmother, mother, and then paternal uncle, and all, it's like multiple family members, sometimes on both sides or one side, have migraine. So we know that it can be passed down through generations. And so we've noticed that inheritance pattern for a really long time. However, it's so common. So it's very hard to study. It's like you want it to be common enough that you can study it. But when it's so pervasive, we actually have the realization it's polygenetic, meaning it's multiple genes likely that can be inherited or caused. And then which ones can be turned on at times with exposures and things make it more likely. So it's very complex to understand it. So when we talk about this condition that I just highlighted, which is called alternating hemiplegia of childhood, it is so unique, right? It is like if you get to the point of making, you rule out stroke, you rule out SUS, you rule out all these infections, and you're like, my left foot, what is this? We've now identified a gene for that. So that gene is ATP1A3, so a very specific gene, but it is often a spontaneous mutation. So what's interesting about this, they often don't have to have other family members with that alternating hemiplegia phenomenon. But this is interesting because these patients do often go on to have migraine, and this particular gene has been identified in other migraineurs who never had the alternating hemiplegia. So it's one of those genes that we picked up on that we can say, this is one of the ones that's probably related to migraine, but we don't fully understand all of the genes out there that cause migraine.
And is there medications for either of these conditions? How are these children treated out?
Yeah, so these children will present with a weakness on one side, and it can last hours to days, and then it can go away, and then it can go alternating. So it can be on the other side. And it can repetitively happen. And obviously it's very distressing. And there is a little bit of a progressive component in that, these children can have some cognitive difficulties, developmental delay. So you really do want to treat it. And also you don't want parents worried we're missing something and continually seeking out medical care, and they may end up with multiple MRIs, multiple hospital stays, it's a healthcare cost for that family and for and resource alignment. So yes, there are treatments. There are some treatments that we use. You could certainly try migraine preventatives. However, there are some specific ones that have been identified in these children as being helpful, and one is flunarizine. And this is a calcium channel blocker, kind of in the family. Another calcium channel blocker would be verapamil, which some people have heard of. But it's particularly interesting medicine that we've used in conditions like this or in a similar family to this that would be interesting to try. And another one is sodium oxybate. So, but there are other ones out there. And so certainly it's something to explore with a neurologist. We try one, we try another, we should keep trying.
Yeah. So verapamil, is that blood pressure medication?
Yep. So calcium channel blockers often do treat blood pressure, and they're often used in migraine management.
Interesting. Yeah, I didn't realize that. I've talked to a lot of patients over the years who have had rare conditions, and after test after test after test after doctor, specialist, etc., finally getting to the point of genetic testing or a physician saying, let's do genetic testing. I have heard and understand that it's very hard to get genetic testing, get access to it, get it approved by insurance. What's your take on that from a pediatric standpoint, given that we're discussing this genetic component of migraine and these rare conditions? What's the challenge around genetic testing?
Yeah, I mean, really, when you brought up the question earlier, also, is it where do we see the field moving, or what are you excited about, or how has the field changed? And really, the biggest change is the advancement in genetics. That really helps identify an understanding of certain grouping of symptoms, but also connect them. Sometimes we learn over time with genetic testing, it's like, well, this abnormality, is here, but they have these symptoms. Same abnormality, and they have these symptoms. So actually, in the past, that's how our health system works. We group by symptoms, right? But maybe we miss that these are all in one group. And so it really does change the physical description or those clinical scenarios we call phenotype. It really changes our understanding of what that patient's journey can be and will be when you start to get genetics involved. And then once you know the genetics and the understanding of how that gene works, it identifies treatments. So really, this is the game changer. You want everyone to be able to have genetics who needs genetics, or anyone who's a clinician says, I want you to have genetic testing for this. You want them to have that access. Problem is, it's expensive, and these are newer techniques, and it is advancing quickly, so they're getting cheaper over time. But also, right as some tests are getting cheaper, the ability and the type of genetic testing is getting updated and more comprehensive. And now you can have things like whole exome sequencing, where they can just look, instead of going, I want to test for this one gene because I'm a clinician, I think I have a strong suspicion you have this. That was the old mindset. And now it's like, just test for it all, and do a whole exome, because then we'll look for this, and a few other things. And maybe there's something I hadn't known about that down the road this will be important to learn. And so whole exome sequencing, or WES, is starting to come earlier and earlier into this discussion. And it's really important to be aware of that for a rare disease, or symptoms that haven't been well identified that everyone says we're worried we haven't sorted it out, because it would delay your diagnosis and also put you through a lot of unnecessary cost and delay in treatment. And if you're testing for this one gene, then this panel of genes, and you're going down that road, might as well start with that earlier. So I'm pretty hopeful because that's the direction this is all moving. And will it come to a point that maybe people, want that kind of thing, even when they don't have symptoms or disease? They just want to know, what is my future going to look like?
Right.
And there's a lot of ethics behind that. And we have to be really careful what that looks like for the future. But it is moving in a fast pace towards that being more accessible to more patients, because in the end, if the test is cheaper, if we get to a point it's cheaper, it lowers all costs. Maybe you won't have as many MRIs. Maybe you won't have as many EEGs. Maybe you won't have as many genetic tests, right? Or maybe we can treat this faster so you're healthier and back to living life and back to work and not in and out of the emergency room, right? Like, so genetic testing is a high cost, but over time it's going to lower costs for our healthcare.
If we could only convince the insurance companies that genetic testing can actually contain costs down the road, but I don't know that we're there yet, or
we're moving in that direction. I've had some
Yeah.
successful examples where we had a child hospital. It was happened a few times, hospitalized, and like, I would love to get this done even while we're in the hospital, not even in the outpatient setting, which is usually the time where we think about genetic tests. So if everything's stable, you're at home, and you're coming in for an office visit, and you have a consultant say, yeah, we should get genetic testing. But there are times that some families don't have that luxury. Their baby or their child is super sick, and maybe we need this understanding to make goals of care discussions. Does this change our plan for this child, and whether or not you want, G-tube or other things? Like, it changes that conversation. We need more information to understand it, and also more information. So as a family, we all understand the why, right? And especially when it's such an awful experience, like, it helps us understand, so we can move forward.
I have two more questions about genetic testing, but did you say at one point too that colic was potentially related to migraine?
Yeah.
My friends and their children are older now, but I heard the stories about, I have a colicky baby, and I don't know that I never really understood what it actually is. But you had said that there is some relation to migraine potentially with colic.
Yeah. So infantile colic is something that a lot of people have either have dealt with themselves, or were that baby that was infantile colic, or know someone who's had to have a child, that had to manage that with a child. So there is specific criteria on how we make that diagnosis. So it's not just meant to be a crying baby. Now you have colic. A lot of babies are supposed to cry. That's how they communicate to parents they need things. But it is a particular thing where, they usually have crying for a certain amount of hours, that occurs on a certain frequency and at a certain age. And so it is interesting because for many, many years, decades, they've tried to understand why a child would be crying and inconsolable and at this certain age and persisting, right? So it makes sense to think of sources of pain, right? Because they're crying, right? So they have looked exhaustively into GI sources of infantile colic. So is it a twist in the colon that's painful? Is it gas? Is it reflux? Is this acid coming up, right? Looking at all these things. Is it nutritional? Is it the type of formulas or other things we're using? Is it how we feed? Is it so much looking into this? And really, the reality is nothing was found in the GI space. We've done our due diligence. So yes, there are certain things you should still try, right? But I don't feel like we've understood what a bulk of infantile colic is coming. So when you see that, it starts to make people go, what else could it be? What else could it be? And for a while in the background, people wonder, could this be migraine, right? Because they want to be comforted. They want to be out of the light. They prefer to be in the darkness and out of noise, like, shh, quiet, babe. And that's kind of how a migraine behaves. So is this migraine, or is this like, a little infant version of migraine? Or is this like a migraine variant? So maybe there is no pain, but they experience a lot of the associated symptoms that happen with migraine. and maybe they haven't experienced the pain yet. So you don't know, and there's no way we're going to get fully an understanding here. But there are folks that are trying to understand this further, and I highly encourage if anyone's interested in this topic to do a little bit deeper review on Amy Gelfand's research, and she's at UCSF. And she has done surveys of parents trying to understand, if you have a child with infantile colic, do they have migraine themselves? And we do know that a child with infantile colic has a higher likelihood of having parents who report they also experience migraine. And so really the answer is trying to see if you have infantile colic and we follow you through your whole life, what's the likelihood of you having migraine? It's a very hard thing to do because you can develop migraine at age 10, but you can also start to develop migraine at age 40, right? And so fully understanding this, it's going to take us a while to answer, but it raises a lot of interesting questions. If this is a migraine or is this migraine, could we treat this like those things, right? And it's not an easy thing to implement in a baby because there's a lot in which medicines are safe in this age group and what would you want to do and the ethics of this and the risk and all these things. But it's an important question to start thinking about because infantile colic is a huge contributor to child abuse. And it's a reality that this is stressful for families. And if we can find something, and maybe it's not a medicine, maybe it's supplementation or adding or adjusting in formula, we don't know those answers, but I think it's important to start thinking about it.
Well, because it does stop eventually, doesn't it? Doesn't colic stop? And so, what do you think is the catalyst?
Yeah, it's so interesting because some of our migraine variants, I like using that term, but it's really the episodic or periodic syndromes is our new medical term for it. But they love to present at certain age groups as the brain develops in a certain phase. It can present these syndromes that we know are related or have a higher likelihood of being related to the migraine genetics. So, the alternating hemiplegia, like they have these bouts of weakness, it's usually in young infancy, right? The Alice in Wonderland is in this usually, doesn't have to be, but 4 to 6 years old. And there's a lot of other, what we call these migraine variants, like cyclic vomiting, abdominal migraine, where they present certain age ranges. And so it's just interesting. Is this one that only presents in infancy and also self-resolves, just like some of these others that happen through your life continuum?
There's just so many aspects of neuroscience that are so fascinating. And when I get an opportunity to do market research in the neurology space, it's pretty exciting for me. I get pretty jazzed about neuro stuff. So this has been so cool to talk about, and especially at a pediatric level where it's even harder to dig for the answers. But Doctor, since you are dealing with parents and you're a parent yourself, and so you can relate to these parents, of course, and empathize, but just knowing this angst and frustration and probably just constant worrying 24/7 when they have a child who has issues like this. And because you are so subspecialized, assuming parents have been around the block a few times with physicians trying to get to answers. And what I'm curious about is some of the experiences that you do hear from parents in terms of this frustrating journey before they got to you. What are you hearing from them that they're being told maybe by other physicians or some of those frustration points? And how do you guide them through that or past that to get them to trust you, really, is I think what it comes down to.
Right. It's hard, right? And trust is everything, right? Because you want them to trust that and you want to earn that trust, but trust opens up the ability for everyone together to agree to the right plan, whether that's more testing, not less, let's not do more testing, and certain treatments or interventions. Some of the things the doctor is having a discussion about are tests that may be uncomfortable or painful or have risks with them. So trust is everything. And so building trust, I think, is, one of the first things I do as a subspecialist who may have had someone see 5 people before they come to me is I would say, why are you reaching out to me now? Or what are you so worried about? What do you think is being missed? And then anytime I take a long, exhaustive, my appointments are very long. So long, exhausting history. At the end, I always pause and say, is there anything I didn't ask that you want to make sure that I know? giving the opportunity to show that it's not just I'm running this and these are my things, because someone's like, why didn't she ask about this? And sometimes that's the most important key to the whole thing. So I want to give that time in my appointment to make sure that they have that opportunity. I will say, though, despite me spending all this time, for folks who've been through a really long medical journey, they could fill days of someone's time with all the things they've been through. I mean, it's a lot, right? So the more a patient can show up prepared, or the family show up prepared to that visit. And what do I mean by that? Like, if you can summarize your journey with dates, hospitalization, this is where my records are, or here are the labs we had, you don't have to be a medical person, but just summarizing what you know, the list of what meds you're on with the doses, it'll cut that pre-visit time down. So you get more time during the visit to talk about what do I think is going on and what else do I need to do. So some of my patients have been on this. It's like, I can read everyone's records. Like, I will do that. And I'm really fast at that too. But it really helps when a patient or family is like, here's that. And then I can go, great, because I know we've done most of that history and I can read it and put it right in the record. And then let's focus here.
I'm always curious about the physician's take on what the patient is assuming is going on in a doctor's office or behind the scenes. So as I mentioned, I hear a lot from patients who have said, my doctor totally, and this is from their perspectives, whether it's happening or not, can't say for sure, but their takeaway in a lot of situations where patients are looking for a diagnosis, they've been going to a lot of doctors, and you hear things like, my doctor totally dismissed my symptoms. I walked away feeling like I was crazy. Or the doctor made me feel like I was crazy. Or they tell me, oh, it's nothing, it's anxiety. We didn't find anything wrong with you. All your tests are inconclusive. And I'm assuming that there's parents who've experienced that with their children and maybe have been made to think that their child is just a problem kid. And maybe this is a psychological genre of issue versus something medical, physical. So if, say, I'm a parent and I'm telling you these things, my kid was dismissed and you doctors didn't spend enough time with my kid, you're not listening to me. How do you kind of counter that or not? I mean, maybe there's some very specific things going on in the background that patients don't understand. And I don't know, maybe they wouldn't care either, but to at least offer some level of understanding of maybe why a child can't get to a diagnosis as quickly as a parent might like.
Yeah, it's such a complex topic. I mean, sometimes it's because pediatric patients don't present right away in the beginning with all of the symptoms needed to make that very rare diagnosis. Sometimes they present over time. The puzzle pieces come in a staggered way. And so that can be challenging, and it can be sometimes easy for me to be at the end of that and be like, aha, they're all together. Let's just put the diagnosis together. And the family's like, how come no one has thought of this? I'm like, because you've taken years to get to this point, and there's been all this before meeting me, right? So it's not to think negatively of that first person. They only had one of the puzzle pieces, right? So you have to have that mindset. And the other thing is, if you do figure out a diagnosis, I would share that with the other doctors. It's a learning opportunity. Some of this is your ability, you have an opportunity, just like I'm on this podcast saying, I want to shine a light on some of these rare or not well-known type of phenomenons. And maybe when you have that rare diagnosis, maybe the opportunity, which will give you peace, is to give that educational, feedback back to those original doctors. If someone told me, wow, Dr. Strauss, I'm off in another state and I found out this rare, I'm like, I would want to know, because it makes me a better doctor. We don't go into medicine, I can't assume for everyone, but I will say most people who go into medicine, this is a calling. We are going in to help people, and it's a learning experience, and the field is fast evolving. So no one will know everything in every moment, and it's always a learning. I show up every day and I'm like, I'll learn something new, and I might learn something from one of the med students or someone else. You have to have that open mindset that there's a lot that I don't know, and it's very humbling. So you can educate back to others, and not in a way like you missed this, and because that makes someone feel awful. It's just bad. I just want to share that we learned the answer, and I'm happy to tell you why and what tests showed the answer. To show that, or here's my clinical update. Let me share that. And The other piece is that sometimes we have to be our own advocates for our health. And I, don't wish that upon anyone, but it may be that if someone in a way dismissed or said, it's not my problem, or this is not my clinic, or this, maybe they weren't the right person or the right specialty, or didn't have that knowledge base to solve it. And maybe it's for the best that they tell you, this is beyond my capabilities. And I think you need to, go on to something else. Or if you sense that, even if they didn't say that, it's okay to seek another opinion. The more you can move to the right people or the right thinkers or the right specialty areas, because sometimes it's not always what you thought in the beginning, that actually makes this process faster. So yes, that the feeling you want the first person you see to solve it, right? And to
Sure.
figure it out. But the reality is not everyone knows all the answers. And sooner you realize that person's not going to solve it, time to move on.
Hem.
And it's hard. It's hard.
Any tips for what that, I guess maybe that tipping point is for a parent that they're just kind of on the hamster wheel, let's say, of trying to find relief for their child? What kind of guidance could you give to a parent to say, hey, if by this time, or you're feeling this, or whatever it might be, it's time to move on to the next physician, et cetera. And then how do they even know what to look for? Like, who's next? How do they even investigate that?
Right. And sometimes it's asking the question, if someone gives you the opening and said, I don't know how to help you with this, or I don't have any other tests to recommend, or I don't know, then you can say, is there someone else or another place that you would recommend? And that's uncomfortable because you're like, sometimes you're like, I don't want them to signal that I'm about to go into somewhere else. But whenever I've encountered that, I'd be like, actually, here are the 3 other people we recommend. It's okay. And, I love having others involved in care because, sometimes the way they took that history, or there's it's okay to have other opinions. And you may, depending on convenience where you live, trying to keep that relationship with the first person. Maybe they couldn't figure it out, but maybe they could, once you figured it out, they could treat it. Right. So, but it's okay to ask, to say, I understand that you don't have another answer. I feel like there's something else. Is there anyone else you would recommend, or should I see another specialty? What do you recommend? Or you can say, although we can't solve this right now, she's still dealing with these symptoms and they've been really disabling or affecting her ability to play or have fun or affecting her family life. Can you treat those symptoms until we can figure out the diagnosis?
Yeah, that's really good advice. And I really like what you had said earlier about how sometimes symptoms don't manifest in kind of one bundle, I'll call it. Maybe it starts in one way, and then as things progress, there's other symptoms that are tacking on, and it kind of layers up to closer to what the diagnosis could be. Or maybe that differential is shortened because now over time, a physician is seeing more of the symptomatology of a particular condition and maybe get to it quicker. But so patience, I'm sure, is tough for parents, for sure, especially when mother's intuition is going bing, 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 and mom knows there's something wrong and certainly doesn't want to be in a position to watch their child or children suffer by any means. But those are really good things for a parent to think about, because yes, I would like to think that physicians go into medicine because it is a calling and are looking to help. And yet I think most people are aware too that a lot of times insurance is the binder sometimes as to, why things get clogged up in the system, as to why you can't get certain testing done, or doctor is bound by, whatever, 12 minutes in an office, whatever it might be. But patients don't always understand that. They don't care. They just need what they need. So as you said, it's kind of a collaboration and an understanding when it comes down to getting a diagnosis for a sick child, especially one who maybe can't articulate exactly what's going on.
Yeah. And it's really stressful for the family and the child. And so when you said that piece of it's all anxiety, yeah, we don't want it to come away missing a diagnosis because we label it as a mental health condition. But it's not uncommon that mental health conditions overlay or develop because you're going through this stressful experience and you have symptoms so having a way to cope as a family or a way to develop, support networks or seek out therapy or, for your children or for yourself, I think it helps you while you're navigating all this because it's really traumatic and really stressful. And there's a lot of things that are being recommended that are scary and may be difficult to go through. So it's a traumatic medical experience, right? So it's hard.
For sure. Dr. Strauss, I can't thank you enough for being with us today and enlightening us on these rare conditions that probably are not on the radar of most parents, but hopefully getting the message out there that there are other things that could be contributing to symptoms and seems like they're pretty manageable or can be managed. And interesting about the genetic component too of migraine and how early it can start. So I want to thank you so much and thank you for the tips and advice for parents as well. And I hope to see you again.
Awesome. Thank you so much. It's my pleasure. And thank you for what you're doing to shine a light on some of these areas and the ethics of medicine and how we navigate all this. It's very important.
Yeah. Well, thank you again. And thank you, everyone, for listening. I'm Laura Nozicka. This is another episode of the Desperate for a Diagnosis podcast. Stay well and keep pushing for answers.
Oh my goodness, that's a wrap on another compelling story. Thanks for listening to the Desperate for a Diagnosis podcast. If you would like more information about today's guests or to find out more about Laura, go to desperateforadiagnosis.com. If you enjoyed the show, please subscribe, rate, and review the podcast on Apple Podcasts, Spotify, YouTube, or wherever you get your podcasts. You can also follow show updates and healthcare news on the podcast's Facebook page. If you would like to be a guest on the show, or if you have any questions, advice, or suggestions for our guests, please email me at lauramarie@desperateforadiagnosis.com. Please note, I am not a medical professional, nor am I affiliated with any healthcare, pharmaceutical, or device company. I am an entrepreneur and an independent market researcher focused on helping healthcare organizations better understand the patient perspective. The podcast is not meant to offer medical advice, but to merely share the stories and perspectives of podcast guests.